One, that are the cardiovascular risks dose related? Yes, definitely they were dose related. And this we can see this in this diagram. When we have given the higher doses, the relative odds ratio was more as compared to the lower dosing. Even with celecoxib, less than 200, the relative odds ratio was less. With the naproxen, less than 1000 and more than 1000. And that is this will lead us to certain guidelines which were later formulated. Another question was, do these effects depend upon the half-life? Definitely yes. Longer half-life, longer the cardiovascular, more the cardiovascular risk, and that is why celecoxib was better as compared to rofecoxib. Third question was, does duration of therapy have an effect? Definitely yes. Risk begin within the first week of treatment. Patients who have had previous cardiovascular event, even 1 to 2 doses of ibuprofen or diclofenac increase their risk for recurrent. And this NSAID use increase the risk of recurrent MI or death by at least 1.5 times during the first 7 days of treatment. Do traditional NSAIDs also have cardiovascular risk? Definitely they have. And we can see that of these traditional NSAIDs, one of them, naproxen, was better as compared to diclofenac, piroxicam, and later followed by ibuprofen. So naproxen followed by ibuprofen was better as compared to the rest of them. And this study in 2016 has come out with another evidence that these NSAIDs they increase the risk of hospital admission for heart failure, even in the normal patient, in the normal individuals also. So we have seen that COX selectivity does have a role to play, and this is seen that relative degree to which different NSAIDs inhibit both COX-1 and COX-2. This determines the likelihood of each NSAID causing cardiovascular event, and this increases as the COX affinity increases for the NSAIDs. So what is the choice? All non-selective NSAIDs and COX-2 inhibitors are associated with increased CV risk. What is the choice? So the choice is that is naproxen up to 1000 mg per day or ibuprofen up to 1200 mg per day. Do NSAIDs affect aspirin also? A person who is taking aspirin, low dose aspirin, and if he concomitantly takes any NSAID, definitely evidence which has shown till now is that ibuprofen doesn't interfere with the antiplatelet action of aspirin. So the recommendation is either you take ibuprofen 30 minutes before taking aspirin or take aspirin at least 8 hours before taking ibuprofen. NSAIDs also affect hypertension, and we have seen those patients who are already hypertensive, there was an increase in hypertension, at least 2 to 3 milligrams of mercury, and this was more in cases of older patients. So obviously, once a person is taking a non-steroidal anti-inflammatory drug for a longer duration, we should monitor hypertension within first month of initiating long-term treatment. And thus, EMEA in 2005 formulated certain guidelines after COXIBs induced cardiovascular risk was seen, and this was that COXIBs should not be used in patients with established CAD. Caution use should be used when prescribing COXIBs in patients with CAD risk, use of lowest effective dose and shortest duration, and warning of hypersensitivity. Later, AHA also came up with guidelines in 2007, and this showed inverted triangle, that is acetaminophen should be used earlier, then non-COX-2 selective NSAIDs, then NSAID with some COX-2 activity, and then COX-2 selective NSAID if treatment is being used. FDA has also come up with guidelines, and this guideline was in 2005. They came up with a revised label box warning, that is, there is a potential for increased rate of CV effect and lowest effective dose should be used. This was again strengthened in 2015, where 2 or 3 things were added. One was non-aspirin NSAID also increased. Second was as early as first week this can happen. Third was longer use, greater and higher the risk, higher the dose, greater the risk. Fourth was even if the patient is with or without heart disease or risk factor, it can happen. And in 2016, another thing was added, that is, it increases twofold increase in hospitalization for heart failure in NSAID-treated patients. Renal effects, obviously, they should be used in these patients with caution: CKD, CHF, cirrhosis, diabetes, patient on ACE inhibitor, ARB, and diabetic. This is important because if ACE inhibitor along with NSAID and diuretic is being used, it is also known triple whammy where acute renal injury can happen. So the recommendation is to monitor serum creatinine, avoid NSAID if possible, discontinue if illness happens, and avoid combination of two NSAIDs. Hypersensitivity, definitely. So one line, that is, avoid all traditional NSAIDs in hypersensitive patients. Few lines about the special patients. One is the children. Ibuprofen is the preferred NSAID. For fever use, paracetamol, and ibuprofen less than 12 years, at least 500 milligrams per day max dose. In pregnancy, paracetamol is the preferred NSAID. In breastfeeding, you can use any NSAID. In older adults, definitely it is one special population. One is low dose aspirin is the common prescription. These are the issues. Age, comorbidities are there, polypharmacy is there. So, acetaminophen, that is paracetamol, should be the first line therapy. Max dose 4 grams per day, and long-term NSAID should be avoided. And if to be used, lowest possible dose, frequency, shortest effective time less than 18 months. Few lines for paracetamol. Just what are the benefits? Minimum GI toxicity, little effect on blood pressure, no association with MI, and that's why paracetamol should be preferred in all the patients for mild to moderate pain. Paracetamol plus NSAIDs, they may provide effective analgesia for some patients, reduce the dose of NSAID, but they have a synergistic analgesic effect? It is again a query. Obviously, there are certain drug interactions with aspirin. It will lower the effect of aspirin. Anticoagulant bleeding might happen. ACE inhibitor, ARB, diuretics, hypertensive, efficacy will get down. So to summarize my presentation, lowest effective dose for shortest possible time of NSAID should be used. Observe caution even if you are giving them for a very short period. Use naproxen or ibuprofen. Naproxen 1000 mg per day, ibuprofen 1200 mg per day, recommended first choice. Prescribe NSAIDs whenever you are prescribing. Obviously, look for the risk factors, and paracetamol is a safe treatment choice. Thank you.
Thank you for Dr. Dixit, and because of paucity of time,
Yeah,
I will not take
I can
questions.
understand.
So it was a very interesting presentation, and brought out very nicely what it says. May I now invite Professor Naman Ansari Usmani. Sir is from this Institute of JNHC, and he's going to talk about rational use of drugs in neurogenic pain.
I know there is my constraint, will try to flash out the next 5-10 minutes, fine.
You can safely take 10 minutes.
The topic which is allotted to me is the rational use of neuropathic drugs in neuropathic pain. So I intentionally added that we have to talk about the rational use of these drugs in our subcontinent, because as our previous speaker said that India is not the West. So we have, and there is a huge amount of economic burden on our society. Once we are starting using these neuropathic drugs, we all know that they are quite expensive and they have their own set of side effects also. So because of that, I've tried to concise it in our Indian subcontinent. I have no conflict of interest, I have no personal involvement in any drug companies. You all know this is the definition which is given by International Society for Study of Pain, that the neuropathic pain is the pain caused or initiated by lesion or dysfunction of the somatic or sensory nervous system. These are the different types of neuropathic pain syndromes. It could be central post-stroke pain, it could be peripheral neuropathy, commonest one is diabetic neuropathy, and then we have post-operative neuralgia, and it could also be a sympathetically associated pain sometimes. I'm not going to talk in detail about this mechanism all, but we all know that the understanding of the mechanism pathophysiology is important to develop the novel therapies which can actually target the factors which are responsible for initiating and causing these sorts of neuropathic pain syndromes. Pharmacological agents which we use in neuropathic pain, if we see from in 1990 and 2010, you will find most of the drugs. Most of the drugs which we are using are in combination with the non-steroidal anti-inflammatory drug, and then we started coming out with few combinations of selective serotonin non-epinephrine reuptake inhibitors, and then we have opioid formulations. But we have very few novel drugs which are based on novel mechanisms, which are actually targeting the factor, the culprit which is causing for initiation of this neuropathic pain. So with increasing understanding of these pathophysiological mechanisms, I am not discussing in detail. We can identify the new targets, and which are more helpful in managing the patient suffering from various neuropathic pain syndromes. And we all know that these targets which have come up recently now, and in the next 4 or 5 years we will see more targets here, that we are targeting the ion channels, we are targeting the neurotransmitters, we are targeting the microglia neuropathic growth factors, and we are working on the molecular genetics as well. This is one of the novel drugs which are there in the market, which are using regularly for the management of neuropathic pain syndromes, that we have in gabapentin, and we all know that they are acting on a particular channel which is responsible for the release of these excitatory neurotransmitters, which cause the initiation of these neuropathic pain syndromes. And now we have another drugs based on another novel mechanisms which are targeting the neurotransmitters as well. They are which are there in the pain modulating pathway, and we have the drugs like atypical opioid in the form of tramadol, tricyclic antidepressants, selective serotonin, and non-epinephrine reuptake inhibitors. This is in nutshell the different drugs. We have different mechanisms of action. Some are working at the peripheral sites, others are working in the central dorsal root horn of the spinal cord, and some are working at the level of brain. Now, I've just brought a few level of recommendations. We do not have any Indian guidelines so far, but we are working on that. Our group from Indian Society is working, and we are hopeful that in the next 2 or 3 months you will find an Indian guideline also. But so far, this is the latest one, which is given by the Neuropathic Pain Special Interest Group of International Association, and they have given certain level of recommendations here, and they said that the first line of drugs you can select any one of them, from tricyclic antidepressants, selective norepinephrine reuptake inhibitors, pregabalin, gabapentin. They said this is the first line agent, and then tramadol. They have this is there in the second line of treatment. Tramadol, topical applications of patches, and they are there, but it's for only few selective conditions like post-operative neuralgia or post-traumatic peripheral neuropathy, and also in some patients who cannot take the drugs orally. But tramadol is basically the second line agent which you can add on with first line agent if you find the pain is refractory to first line agents. And then finally we have strong opioids which are there in the third line also. But we all know that in our country like India, we have limitations with these drugs. They are not available in the openly market, and they have their own set of side effects. And there are some inconclusive recommendations also. I'm not going to detail into this. Combination therapy is there in the market. Yes, it's a good, attractive option, but they have their own set of side effects. So we do not find any support for any specific drug combination till today in any of the guidelines so far. Now this is, I just want to highlight a few important recommendations as far as the Indian setting is concerned, because here we need, this is the most important slide of my presentation, that we should be concerned, why we are so concerned for Indian settings, that availability of drugs. We do not have all the drugs which are available here. I will show you in the next 2 slides. This is the capsaicin 8% patch used for post-operative neuralgia, not available so far in Indian subcontinent. Another important drug is cannabinoid Sativex, used in central neuropathic pain patients of multiple sclerosis. Again, it's not yet available in Indian subcontinent. So availability of drugs is an important issue. Second thing is the accessibility of the drugs. Like as I said about opioids, they are not available in the open market.